Hi, everyone. Welcome to today's webinar. My name is Chad Severs. I'm the project manager for Arkansas Building Effective Services for Trauma, which operates under the UAMS Psychiatric Research Institute. I'll let our speaker introduce himself here in just a minute. Today's webinar is going to be an overview of the Child and Adolescent Trauma Screen, which is also commonly known as the CAPS. I'm going to do a few housekeeping announcements. We encourage you to ask questions during the presentation. We're going to try to reserve time at the end to answer those, but to ask a question, the feature is on the right side of your screen, so just be sure to type those in as they come up. If you'd like to earn a CEU, just be sure to stick around to the very end. We'll have a code that's given. If you happen to be watching with the group, it's helpful if you let me know who the person who signed in was, and that way I can kind of verify attendance. This webinar is being recorded, and we'll upload this presentation to our website shortly. And be sure to check us out on Facebook. We started our evidence-based trainings for therapists in 2010, and we post about upcoming training announcements there on our Facebook page. And we started our webinar series in 2012. So we've been doing a lot of these trainings for a number of years, and that's just a good way to kind of know what's going on in Arkansas and what trainings are offered. So our presenter today, Dr. Benjamin Siegel, the child psychologist. I've known Ben for a number of years. He's one of our national TSCBT trainers, and many of you who are listening might have actually have attended the training with Dr. Siegel. And so anyways, I'm going to just kind of turn things over to him and let him introduce himself and his topic a little bit more.
Yes, well, welcome everyone. Ben Siegel here. Chad did a great introduction of me. So I'm also part of ARBEST within the UAMS Psychiatric Research Institute. So I'm happy to be here today to talk about the CAPS, Child and Adolescent Trauma Screen. The reason why we're having this presentation is we've made a switch as part of ARBEST from the measure that we had been using since the beginning of the project in 2010, the UCLA PTSD Reaction Index for DSM-4. And at this point, we are in DSM-5, so the DSM-4 version of the UCLA is a little outdated. And so we reviewed available measures, ones that were in public domain, that we were able to put on our website, offering free scoring for. The CAPS is the one that we came up with for a variety of reasons that we'll go over today. There are still a number of other good measures. The UCLA PTSD Index for DSM-5 is a wonderful measure. It is costly and not in public domain is the main reason why we didn't use that one. There's also the Child Post-Traumatic Stress Scale, CPSS. That's a great measure. But we'll be talking specifically about the CAPS today. So just talk generally, why do we promote using assessment and specifically using standardized and normed measures? First of all, having an opportunity to have the child and or the caregiver respond on paper to a list of traumatic events that have happened or could have happened in their life, and acknowledge whether or not those happen. So for instance, most trauma measures have an event screener, and the CAPS does, which we'll go over in a moment. But ask whether or not certain traumas have happened or potential traumas have happened over the child's lifetime. Things like natural disasters, sexual abuse, physical abuse. Oftentimes that may not come up in our clinical interview. We may not ask it in a way that prompts the caregiver to view that as potentially something potentially harmful, or they may not know certain events their kids have been through. They may have had some advice when their child has gone through a traumatic event. Maybe they were told, don't talk about it. Your child may forget about it. And so they may have been through an event, but they may not know if their child remembers it or not because it was never talked about afterwards. Oftentimes, talking about trauma symptoms and trauma events are easier when it's not face-to-face. So some caregivers may, or kids may feel more comfortable answering questions on a paper and pencil version. Children may report different traumatic events that their caregivers weren't aware of. And also, we want to use assessment measures because lots of kids are resilient after traumatic experiences. We know that the majority of kids, roughly 2/3 to 3/4 of kids, generally speaking, who have been through potentially traumatic events, don't go on to have symptoms consistent with PTSD or post-traumatic stress disorder or traumatic stress symptoms afterwards. They may have the acute reaction or distress afterwards because it may be a difficult event, but most kids, majority of kids, with supportive family or resilience or going on with life and having enjoyable things or whatever it may be, most kids don't go on to have long-term symptoms of PTSD. So, doing assessment is another measure where we can see if kids have been through difficult events and they're not having trauma symptoms, we can promote sort of healthy healing and resiliency in children, which is a very good thing. The other things why we want to use sort of standardized and normed measures is that they're standardized and normed. Standardized meaning that the administration is consistent across, so the forms are fairly standard, the instructions are standard, people administer it in a standardized way. Normed meaning that there's some type of data used on a population to assess what are sort of at-risk or clinical symptoms of post-traumatic stress. And so when we give this measure, we know that compared to other children, if they're having these level of symptoms, we know that that's a good cutoff that leads us to believe that there are symptoms related to post-traumatic stress disorder. The other piece is clinical assessment measures, standardized assessment measures can be really good for observation as you're administering the measure, and I will point out certain places that are good for observation when you're giving the measure as we go throughout the presentation today, but you're gathering more information in addition to your clinical interview. When you ask the questions, is the child becoming avoidant, or is the child suddenly underneath the table, or are they starting to be more fidgety, versus are they able to talk about it and maybe they're a little hesitant, but they're able to talk about it and you're not seeing much sort of arousal symptoms or avoidance. That may tell you something about whether or not we need to proceed with trauma treatment. And I do want to stress that although we highly promote using these measures to help with clinical decision making, that the decision to proceed with trauma treatment or any treatment based on assessment, that this is just one piece of the puzzle, that you're going to incorporate other information like your clinical judgment, your clinical interview, any other assessments, your work that you've done with the client so far to use your best judgment on whether or not we're seeing PTSD or post-traumatic stress symptoms in that child. And it's often used to determine at least the initial course of treatment. That at this assessment point, we're thinking that either treatment focused on trauma is appropriate or not. And assessment is ongoing. So you may start thinking that you're seeing a lot of trauma symptoms, but then you start treatment and what were initially reported as trauma symptoms could be some symptoms of some other disorder or difficulty, or the other side that they're sort of reporting some trauma symptoms, but you're not sure, and then you start treatment, you do some psychoeducation on trauma, the kids and the caregivers become more comfortable with you, and they're sort of more trauma informed, they know what trauma symptoms look like, they may report more trauma symptoms, and so you might give an assessment measure a little bit later on treatment to see if they're reporting more symptoms versus that first administration. Other things that, part of good trauma treatment is not avoiding talking about trauma. We know that a core feature of PTSD and in post-traumatic or traumatic stress symptoms are avoidance. And for some, there is a healthy avoidance. It can be a coping mechanism. But when we see it rise to the level of a clinical disorder or clinically impairing, avoidance has gotten in the way of healing. And the way people often cope with difficult things is to avoid, and that avoidance leads to them not making sense, processing, healing from those events. And so by the process of giving these measures and talking about different traumatic events and reactions, it's setting the standard or the stage that we're going to slowly talk about difficult things to make sense, to heal, and to move on. That piece about gradual exposure, you're going to be slowly talking about difficult events and not have bad things happen, and build up coping skills and healing skills and safety skills so that the child doesn't avoid in the future when they're having distressing thoughts or memories. They have effective coping skills to treat it head on. So that it's another way that we're using assessment measures is that from the beginning we are talking about trauma. Often assessment measures results from your clinical interview, from your assessment measure. You're going to incorporate into those beginning sessions for making the case with the child and the caregiver that trauma treatment is necessary. So reporting on, this is in your own words, your own report, you're having these symptoms related to the sexual abuse that occurred. Luckily, we have a treatment for that. And whether it's child-parent psychotherapy or TFCBT or some other evidence-based trauma treatment, psychoeducation is usually a part around, here are your trauma symptoms, this is why we're doing this modality. And then typically you move on to coping skills and continuing to talk about trauma, and then leading into some type of processing of traumatic events, trauma narration or something like that. Assessment measures, they're good for the beginning. They're also good for assessing progress throughout treatment. You may give it, in the middle of treatment to check you're certainly seeing, you may see some reductions in symptoms, but this is a way to measure progress compared to at the beginning. You can, share the scores with the caregiver, with the child, but then also as you're thinking about graduation, giving a few sessions before just to make sure you're not missing anything. But also that the assessment scores can be used as part of graduation to show all the progress that's been made. Oh, and lastly, also important, sort of using these measures, the CAT specifically, within ARBEST, if you're involved in ARBEST training, we report just basic information about numbers of kids served, trauma types and scores, never any identifying information, but that helps us to report progress to legislators, funding folks, just to show how many kids have been served by ARBEST, how many assessments were given. And for those of you that are completing consultation calls for TFCBT, specifically reporting on the CATs is a requirement of those calls. So let's talk about the CATs, Child and Adolescent Trauma Screen. So it's a brief assessment tool that checks for trauma exposure. That's that event screener I talked about before, and current PTSD symptoms. There are 3 parts to the CATs, which I will go through in a moment, but those 3 parts are needed for a good trauma assessment. And we'll talk about that more in a second. It does match DSM-5 criteria. It is free. It is relatively easy to score. I will go through scoring with you today. We will have free automated scoring from the ARBEST website, where you can enter that and score it with you. I also want to let you know, all of you that are signed on, there is a handouts section of this webinar. There are the English versions of the CATs available, so you can look through it as I talk. There is also the scoring sheet and a guidance sheet on how to administer and talk through with the child and caregiver what certain symptoms mean. So you can look at those. They're also available on the ARBEST website as well too. There are Spanish forms available as well. I couldn't post those or add those to the webinar today because we can only have 5 attachments. But just so you know, there are Spanish versions. There is some good reliability and validity data for the measure, meaning that when it's administered, we have reliable scores, meaning that the scores are relatively consistent, which is good, because we don't want the child or the caregiver giving one report, one day, and the next day they're completely different scores. So it's reliable, and validity means that it's good for discriminating between symptoms of PTSD and other disorders like ADHD or oppositional defiant disorder, mood disorders, and so forth. So there's some good preliminary data on the soundness psychometrically. There are 2 forms. There's a child report form for kids aged 7 to 17. So that means that the child will report on their own symptoms. There is a caregiver report for that same age range for kids, so 7 to 17, and the caregivers can also report on symptoms for kids 3 to 6. So the caregiver version goes from 3 to 17. The child version, where they report on their own symptoms, is 7 to 17. Why the different age range? It's what we know about children's ability to have the insight and developmental level to be able to distinguish how frequently they're having certain symptoms. Anywhere below 7, sort of this type of measure, sort of discussing frequency and how often, is a little too developmentally complex for those preschool children. So that's why it's 7 and up. But for the gap, when we have those 3 to 6-year-olds, the caregiver can report on 3 to 6-year-olds. And generally speaking, the older children are, the better reporters they are. So if you have an adolescent, you're going to give more weight to that child or adolescent report. The younger the child is, the better the caregiver is at reporting symptoms. For the adolescents reporting on themselves, they become more independent. They're more aware of their own internalizing symptoms, and those aren't often picked up by caregivers. Sometimes they are. For younger kids, again, it's the developmental level and the insight into their behaviors that caregivers tend to be better reporters of things like nightmares or talking about certain events or being hypervigilant or startle response, things like that. Ideally, you'll give both a child and caregiver measure just to compare answers, and we'll talk more about that towards the end of the training. So there are, the CATS has a traumatic event screener, so it assesses for trauma exposure. I'll show you pictures in a second. And then it has current symptomology within the 4 sort of clusters of PTSD symptoms. Re-experiencing, avoidance, negative moods, cognitions, and arousal. So ask questions for DSM, PTSD diagnosis within those domains, and then it produces overall traumatic stress score. All right, so this is the form. This is the youth report, so this is the 7 to 17, and this is the first page of the CATS. It's not the full page, it's just a screenshot of the top. And as you can see, this is the event screener. It just goes through a number of different events, and the child answers whether or not they've been through certain events. So have you been in a natural disaster like a flood? Yes or no. And then you move on to the next one. There is also, at the end of the list, there is an other, because it's not an exhaustive list for potentially traumatic events. And so the other question is important just in case we don't think of something. So the kid goes through it, endorses which ones have occurred or not. And then the second part. So this is the first part. We talked about the 3 parts of a good trauma assessment. The first part is an event screener. The second part is asking about which one is the most impactful or bothersome now. So if the child endorsed several different trauma types, so there was a tornado, there was sexual abuse, and there's domestic violence in the home. And then it asks, Okay, which one of those is most impactful now? And the child reports the sexual abuse. The important piece of that is you're going to want to know more information later. You're going to ask them open-ended questions about, tell us a little bit more about these traumatic events. You're not doing that yet. You're just having them answer which is most bothersome now, and then they answer the rest of the questions related to that. When we're thinking about PTSD and PTSD treatment, we're typically focusing on one type of traumatic event that is most impactful. That's not always the case. Oftentimes kids have several different events that are intertwined and kids can't distinguish which one's most impactful now. That's okay. The kiddo can report, these three are bothering me, all of them are bothering me, I'm having symptoms for those now. That's completely fine. But there is a question that helps you guide treatment to see if there is one type of traumatic event or a series of traumatic events that are more impactful now. And then the third part of a good trauma assessment is current functioning related to traumatic stress symptoms. So as you see, this again is just the first part of this page or this section. You mark how often these symptoms have occurred in the last 2 weeks related to those traumatic events they endorsed before. So bad dreams and reminding you what happened. If they're having them nightly, that would be a 3. And the child then goes through these questions and answers how frequently they're having those trauma symptoms. And as you'll see, there are a couple examples. The ones on the top are sort of those intrusive symptoms. So having things come into your head when you're not wanting, having nightmares, sort of reliving it again, that re-experiencing, intrusive memory kinds of things. And then sort of it starts at the bottom around avoidance, trying not to think, staying away from people, and then it continues throughout. So the child or the caregiver would then answer these symptoms for current symptomology, and then the very last part of the CATS is getting at the symptoms that they're having, that they marked about before. Are they impacting functional impairment in things like school, getting along with others, family relationships? That's that DSM-5 criteria around functional impairment. So you're getting all the pieces you need if you want to make a PTSD diagnosis from this. So then how do you score? What do you do with this? And I'm going to get to that in a second. But what I do want to stress is, okay, how do we use this clinically? We've gone through the measure, they've gone through, and I'm just going to skip back a few slides. This is the beginning of the CAT, so they've gone through their event screener, they've chosen which one's most bothersome in current symptoms. So then what I would recommend clinically is, after you've gone through that, then get some more details. I would start with the one that they said was most bothersome. Just some basic details about what occurred, details, just enough so you kind of get the sense of what happened. It doesn't have to be a long, in-depth conversation about all their thoughts and feelings. You just want to get another sense of the details to help you guide treatment, but also you're getting observations around their avoidance, their arousal, to sort of help you make the decision. Once you've got your scores, you've done your intake, are they able to talk about certain events? Are they having emotional sort of arousal related to it? Or are they able to talk about it? And they're already sort of at the sense where they're saying, yes, this happened, and yeah, it was this, this, and this, by this, this, and this. And, I was in therapy before, or I'm doing okay with this. If they're at that point and you're not seeing, that arousal, and you're not seeing a lot of symptoms endorsed on the current symptomology, that may be a case that you don't need to do trauma work. On the other hand, if, as we talked about before, as you're going about it, they can provide some basic details, but they're sort of, you immediately see some sort of hesitation, avoidance, and maybe some fidgetiness and things like that. So then I would recommend, after going through that one that they said is most impactful now, just getting some more information on the other events that they said occurred. So, my example, also domestic violence occurred. So tell me a little bit about that. So we're sort of bringing those events to life. And then the last part, I would go through some of the symptoms that they endorse, particularly the high ones, and get a little bit more information about that. So, so again, we're on this page. So feeling as if it happened, feeling of what happened is happening all over again, you sort of all the time. You know, tell me when that's occurring and what are you thinking about, what's going on. Just getting some more information about the symptoms, along with your clinical interview as well too, just to try to get a sense of, as you're doing trauma treatment and you're making the case for the trauma symptoms that they're having more information is going to be helpful in getting the child and caregiver on board. That you can say, we're targeting these specific symptoms that you're reporting you're having difficulties with or impairing, and those are exactly the symptoms we're going to try to reduce. So then you've gone through the measure, you've got your scores, you've brought it to life, then you get to score it. And scoring is very easy on the CATs. Basically, on this page, this is the one that talks about current PTSD symptomology. They answer 0, 1, 2, or 3. You go through all the answers and score and add up those 0, 1, 2s, and 3s. There are either 17 or 20 questions, depending on if you use the child or the caregiver version and the age. But you just add it up. So if there are 20 questions and the child answered 0 to all of them, you're going to get a total score of 0. If they answered 3 to all of them, you're going to get a total score of 20. You do not score the functional impairment part, this part, just these numbers, these questions, 1 to 17 or 1 to 20. That's your total score. And then what does it mean? So if you have a child report, remember that when the child reports on their own symptoms, if they're in the age range of 7 to 17, if the total score is 15 or more, that means that possibly we're seeing PTSD symptoms and sort of the at-risk sort of level of trauma symptoms, that you're thinking about doing a trauma treatment if sort of this measure matches your other clinical observations and interview. Same thing for the caregiver report. If it's 7 to 17, it's 15 plus. For the 3 to 6-year-olds and the caregiver reporting on their child's symptoms, it's 12 plus. So 12 plus for them means PTSD symptoms, there may be at risk, we need to monitor these, we may need to refer to a TFCBT provider. They're not off the chart or at that probable PTSD level, but they're at the level that is concerning, that we want to monitor, we want to start treatment. The reason why it's 12 plus is there's less questions for the 3 to 6-year-olds, just in case you're asking. And so there is a form. This is one of the forms that is attached to this webinar just to help remind you and sort of think through what different scores mean. So this is the 3 to 6 version for caregivers. You'll notice within this yellow part, a score of 12 plus, you're in the moderate range, meaning you're seeing some trauma symptoms. We need to get more information. We might be starting TFCBT if it matches sort of your clinical observation. You've got enough to start. If it's 15 plus for these 3 to 6-year-olds, then we're seeing clinically significant PTSD symptoms, and if it's matching your other clinical interview observations, we're certainly thinking some type of trauma-specific treatment like TFCBT or child-parent psychotherapy and others. If it's 12 or below and it matches your clinical interview and observation, that means that the child's doing fairly well. You still want to monitor symptoms, maybe do some education on these are the symptoms to watch out for in the future. If you see these, come back in, but overall, they're not having the level of traumatic stress symptoms that would lead to them needing trauma-specific treatment. Same thing for the 7 to 17-year-olds. So this could be the child self-report on their own symptoms or their caregiver self-report. The only difference is, it's 15 plus. So moderate trauma-related symptoms, 21 plus for this age range, we're thinking probable PTSD. I do want to stress, for those of you that have been trained in TFCBT, we don't need a PTSD diagnosis to do TFCBT. We just need trauma symptoms, and that's true for really any evidence-based trauma treatment. I do want to spend some time talking about using the CATS within the acute stress phase. So you all know sort of when kids have difficult events, potentially traumatic events, universally we see some type of distress. When kids go through scary, frightening events where someone could be killed or their physical integrity is threatened or been in a car accident or natural disaster or sexual abuse, it's natural to have some elevation in symptoms. That's sort of why we have the acute stress disorder sort of stress phase, that, within that 30-day window, it's likely that kids are going to have some type of symptoms, acute stress type symptoms. But oftentimes, if we follow the kids a little bit further, they may be part of that 2/3, 3/4 of kids that don't go on to have sort of longer term PTSD or traumatic stress symptoms. But there are kids that, when they report high symptoms within that acute stress phase, could need trauma symptoms or trauma treatment later. So you can certainly use the CATS as sort of a screening tool within that phase. And remember, when we're talking about acute stress, we're truly meaning that the event has occurred within that last roughly 30 days. I know most of the cases we get in our clinic, that's not the case. It's not that acute trauma. It's, sexual or physical abuse or neglect has been going on a period of time. Maybe it's been disclosed recently, but the actual event wasn't just one time during that past 30 days. So just know that I think in most settings, this may be the exception, but know that you can use the measure just to assess what symptoms you're seeing now, but not necessarily make decisions on what long-term treatment needs to be. If you're seeing high symptoms, certainly that could mean providing some psychoeducation, safety, coping skills, building work around managing current situation. Because this trauma happened, how has it affected the family? Are they in a new living situation? Has someone, passed away? Are they no longer able to see someone? So focusing on supporting, families in the emotional, physical sort of safety where they are at. And monitor symptoms and sort of give the CATS again a little bit later to see if we're still seeing trauma symptoms or not. If they aren't, that's great. If they are, then sort of using the work that you've done in transitioning into more of a trauma-focused treatment. So just know that sort of in that acute stress phase that high scores don't necessarily mean trauma treatment is needed at that point. It means you can certainly work on coping, stability, psychoeducation, and monitor those symptoms for later. Okay, we're going to have plenty of time for questions, and I see some people writing those in. I will go over some frequently asked questions in a moment, but I just wanted to let you know, those of you that have an ARBEST account, the forms are all available there now. So the Spanish versions, the English versions, the sort of score guidance, the cutoffs, so forth and so on. And on July 1, we will fully make the transition through the ARBEST website to be using the CATS only. So the UCLA will be completely phased out. And so at that time, we'll have automatic scoring for you, which you can use just like you used the UCLA before to keep track of your kiddos. You'll get a nice graph. It'll be much nicer than before. It's going to be tablet friendly, I'm told, and mobile phone friendly. So it's a step in the right direction. Our original website was built in 2010, and technology has come a long way. So we're excited about it. You will have your automatic scoring. More information about the CATS can be found at the website below. All the things that we've mentioned are there, including the article on psychometric properties, I believe. If not, we can send it if you're really interested in that. So some frequently asked questions that often come up around assessment. First of all, do I give child, caregiver, or both forms? Maybe in a situation where we've got a 9-year-old and they're in a new foster home. and the foster parent doesn't know the history of the child, and they don't really have a good sense of current functioning yet. I think in that case, you have to use your clinical judgment, that use the report that you have from the child, and try to have the caregiver report on maybe current symptoms and see what they're seeing. Maybe get some information from collateral resources like, maybe a DCFS caseworker, previous foster homes, if there's been any testing or a PACE evaluation. So sometimes there isn't a caregiver, and that's okay, or at least a caregiver that can't report on accurate symptoms yet. Some of you may do school-based work and work with adolescents, and it may make the decision that it's not appropriate to involve caregivers for a variety of reasons. And so yes, you can certainly use that child-adolescent measure over that caregiver measure. Ideally giving both forms to compare those forms, and then as I said before, generally speaking, put more weight into the caregiver report when the children are younger and the self-report, adolescent child report when they're older. But also know that there are all sorts of reasons why kids and caregivers will report high scores or low scores. And so again, this is not the only piece to decide if you're doing trauma treatment. You may have a child that has been in therapy a long time, and they're very savvy to the fact that if I endorse these symptoms, I have to talk about these things. And so their avoidance might come out on those score measures. And so you may get a score of 0, which is really hard to do on an assessment measure of trauma. So that's where you use your clinical judgment, your observations, but also hopefully you have a caregiver report where you can sort of get a sense of what they're seeing in the child as well too. Even if you get really low scores on both measures and your clinical judgment is saying, yeah, I'm really seeing these symptoms, you can certainly start with trauma treatment. You can provide some psychoeducation, get to know more about the kids, have them feel more comfortable, and give those measures again. Again, sort of that question on what if my scores do not match my observations? Avoidance is one. We also get caregivers who, I guess we use the term cry for help, where they report high scores on everything because they're really overwhelmed. So know that we might get artificially high scores from caregivers, even from kids. But in those cases where if you're giving more than just the CAPS, you may see high scores on everything across all sort of assessment measures. And even in your clinical interview, they just have a lot going on and stress, and these kids are difficult for a variety of reasons, or could be difficult, or they view their kids as difficult. So know that extremely high scores don't always mean trauma treatment either. You have to take everything into context. Kids and caregivers may report different symptoms. That's okay. You have to use your clinical judgment, the age of the kiddo, the history, how involved caregivers may be in that child's life. And then despite all of this advice, there are going to be those kiddos that you're just not sure. That it sure seems like there's trauma, but then you could make the case, well, it could be related to something else or additional stress that's not really trauma stress. But your clinical gut is saying, well, there could be trauma, and I just want to explore more. That is okay. That is why, most trauma treatments or most treatments are flexible, that, specifically, for instance, within, TFCBT, there's the prac skills, there's the stabilization, coping skills, where, those are, teaching general information about trauma, some basic, parenting skills, relaxation, coping, identifying feelings. And so you can start with sort of more basic skills building, not necessarily tying it to trauma symptoms yet, but as you see the kids more, as they know information more, you may give another assessment, or as you proceed, you may say, okay, I'm really seeing trauma symptoms now. So as the caregiver, child is making the connection as well too, we're going to proceed with the trauma treatment, versus you're doing skills building and you're just not seeing a trauma theme. and maybe there's a different cause to sleeping difficulties or something like that. And maybe it's just general anxiety or depression versus anxiety related to trauma or depression related to trauma. So know that you do have some flexibility within the models, that you don't always have to know after your assessment if you're going to proceed with a trauma treatment or not. That's why we have adjustment disorders for diagnosing that they are our friends in such situations, or other traumatic stress disorder. Those are those cases that there certainly has been an adjustment in difficult events. We're not quite sure whether it reaches the level of PTSD or not, and so sort of that is certainly appropriate in that case as you're gathering more information and you're trying to determine, maybe some of the anxiety behavioral difficulties, if they're trauma related or not, and then revise those diagnoses later. Okay, so that is my frequently asked questions. Chad has been manning the question line, so he's going to ask some questions that have come through, and I will do my best to answer. Okay, if you have more questions, ask them now.
Okay, yeah, we've got a couple of questions in here, and then we'll advance to the CEU slide. Let me just kind of read these to myself here.
Oh, I can do one that is fairly that I can go over again. A question about how to repeat the scoring. So I'm just going to scroll back up. So this is not the full page, but this is the page where you're going to do scoring. And so this is the child or the caregiver will answer these questions for how often they're having symptoms, and then you're just going to, as you see, 0, 1, 2, or 3. You're just going to tally up the total score. So if it's a 1, then a 2, so 1, then 3, then 4, then 5, then 7, then 9, then 11. That would be the total for this part. There's more questions. You just add them up like that. And if you have a 7 to 17-year-old, it's 15 plus. If it's more than 15, you're thinking possible traumatic stress symptoms. For that 3 to 6-year-old, 12 plus. Hopefully that answers that.
Thank you. Another question came in is just what's the recommended, the frequency to administer the CATs through the course of treatment?
Okay, that's a good question. Great question. Recommended frequency to give the CATs. I think the best times to do it are when they're most clinically helpful. So I think the standard ones are at the beginning of treatment to try to determine treatment, and then close to the end of treatment, when you're trying to make sure that there aren't any remaining symptoms that you might have missed. Just you might feel, and the child and the caregiver may report reductions in symptoms. It's just another way to make sure we're not missing something. I think another good time point is if you're feeling stuck, or you just kind of want to monitor progress, maybe every 3 months is a good time frame. I think within TFCBT, if we have a TFCBT provider on the line, I think another good time is doing an assessment measure as you're getting ready to start trauma narration, just to see improvements there, but also have another time point to see, for the family, was the trauma narration where we really saw reductions in treatment. So really, whenever you need to, I would certainly recommend beginning and end. And if you're seeing the kids for a longer period of time, then giving it more frequently, because you might need to sort of change directions if you're not seeing trauma symptoms or something like that.
Yeah, and another question just came in just to clarify, to administer part 3 for the follow-up administration. I think that's right. And so for a couple months here, we're going to have just paper copies available, but when it is available on the ARBEST website, when you are ready to do a follow-up, just that part 3, or the second part where it asks about the symptomatology, that's the one you'll be asked about for the follow-up questions. Don't get anything to add to that.
Yep, that's perfect. So you don't have to give the whole thing, unless it can be good practice just do the event screener just to make sure nothing else has occurred. But I think for most cases, that will come up during your course of treatment. So I think doing that last part about current symptoms related to the trauma, that part 3, yeah.
And then another individual asked, how do you proceed if a client scores really high in the CATs, but denies that a trauma is impacting them? How do you wrestle with that?
Yeah, so that's a tricky one. So you've got a kiddo that's scoring really high on the CATs, but denying there's an impact. And so I think one thing would just be to pull out that measure and get more information about it. And so sort of bring those scores to life, making sure that when you do that, there are a lot of symptoms within trauma that do overlap with other disorders. If we're thinking about the sort of the hyperarousal, hypervigilant kinds of symptoms, there's questions around difficulty concentrating and things like that. So I think one way is to go through the measure, have the child sort of explain what those scores are. And if you're hearing trauma, it would be hard for him to argue with his own words. But if you're not, it may mean that, okay, maybe we're not getting a great sense of those trauma symptoms because we're picking up on something else. I think another way, oftentimes kids don't understand the time frame. So sometimes it may be going back and, giving a better sense of, what is all the time, what is, half of the time, but also in the past 2 weeks, which can be tricky for kids. So oftentimes when I'll do that, I'll provide some kind of anchor. So having the kids or the caregiver think about, okay, 2 weeks ago, what was going on? Was there anything important or memorable? Okay, what happened since then? What are some important things that you can remember in the past 2 weeks? And then say, okay, that time frame is what I want you to answer those questions for. Because sometimes kids, caregivers miss that, and it's just like looking over the past 5 years of their life, and they're like, this happens all the time. So some of it could be just making sure you've got the clear time point that they're answering for, trying to get some more information about they're having trauma symptoms or not when you sort of do those follow-up questions. And then the piece, along with your interview, if you are seeing sort of other trauma symptoms or getting observations that they're having the trauma symptoms, I would, not sort of try to tackle, well, I'm seeing trauma symptoms, you reported this versus not. I wouldn't do that. I would just move into psychoeducation and provide some information around trauma and then try to link it to, well, these are the things that you reported to me. I wouldn't even try to challenge, well, you said there's not an impact, but you're saying these things are happening. So I would just try to tie it into that. If you sort of rule out the ways that maybe it was administered sort of an odd way, or maybe they didn't quite understand what they're answering for.
Okay, thanks. And
then I think there are lots of reasons why kids may sort of not admit sort of the impact. It may be sort of that machismo, or like, I'm tough, and if I admit that this bothers me, then I'll have to, that's not safe to do that, and I grew up in a place where presentation is important, and I don't feel comfortable if I'm safe. And so what may happen over the course of treatment, when you're doing more feeling identification work and feeling more comfortable, and you start talking about thoughts, you may be able to sort of slowly chip away at that. Well, it's not bothering me. It could also be avoidance. And so that's, as you slowly talk about trauma, that avoidance will decrease.
Dr. Siegel, could you just clarify again, just a couple of questions about what are parts 1, 2, and 3 for the CAT? And, they don't necessarily parts 1, 2, and 3 on the actual assessment measure. It's just our way of sort of trying to organize it for you. Yeah,
so that's my wording. It does not say part 1, 2, and 3, but part 1, if you're looking at the screen, hopefully you see part 1 is the traumatic event screener. So just going through traumatic events, yes or no. Then part 2 is which bothers you the most now of those events that you stated had occurred. And then last is current symptoms, current PTSD symptoms in the past 2 weeks.
Okay. I'm just going to advance it to the CEU slide. Let's see here. So if you are interested in receiving a CEU, please sure to email me, and if you can tell me your first and last name, that just makes looking up attendance easier. And if you're watching with a group, if you could just tell me who the person that was the one who signed into the webinar, I can just kind of verify attendance that way. If you happen to be watching this at a later date and time on our YouTube channel, we only award CEs for attending live webinars. So we'll kind of leave this up here and we'll continue to take a couple more questions we've got some time. And let's see here. Any kind of like recommendations, Dr. Siegel, for best practices to administer an assessment? I know you talked about anchoring with dates and stuff, but any other kind of words of wisdom for folks?
Yeah, let me think. So I typically, when you're doing sort of your regular interview or clinical intake, I start fairly broad, getting, developmental history and, general symptomology and things like that. I do trauma work more towards the end and asking about that, and that's just more of the setting that I'm in. I'm in more of an outpatient general setting. Some of you may be in, a CAC or a clinic that specializes in trauma, and so you may ask those questions a little bit earlier than I would, but the trauma questions, I'll ask sort of the general questions around, talk about, difficult events your child may have been through, give some examples, sort of, asking questions about impact and general assessment of PTSD symptoms. But I'll leave the trauma assessment measure till the end, but I also have the flexibility that I can have them come back and do that. So sometimes it's not always done within one session. Maybe they'll come back, I'll get more general information in the first appointment, and the second appointment will be more gathering information about trauma and trauma symptoms. I would recommend doing it one-on-one with the child if you're going to do a child form. Adolescents can fill it out themselves, but I would point out certain important pieces, like circle the 2-week kind of thing. But make sure you go over it afterwards. So if they say endorse certain things, get more information about that, bring the symptoms to life. For younger kids, I'll give them choices. We can work on it together. I can read, you can mark the answers. You can read, I can mark the answers. You can do both, but I'll sort of be looking over your shoulder for questions. For younger kids, I'll also do some kind of, I'll use a ladder to talk about the numbers and sort of, on the ladder, 3 will be very high, 2 will be next to high, 1 will be towards the bottom, and 0 would be at the bottom, and talk about, okay, when you answer these questions, the higher you are, the more things happen. So if a 3, it means, it's happening a lot because it's high. A 2 is sort of some of the time or half the time, and so forth. Caregivers, they can report and complete it on their own in the waiting room, as long as you go over those questions and bring them to life. That's sort of all I can think of at the moment.
Thanks. We've had a number of questions come in that are kind of case specific, so we will get with folks after the webinar and kind of address those. Or if you think of a question after today, you have my email there. I can forward that on to Dr. Siegel, and we'll get with you. So kind of just take last call for any burning questions that folks have.
Yes, well, I'm happy to help with clinical questions. We are trying to, for questions more specifically to the cats. And so if you have any questions specifically on the cats, how to administer any remaining questions on that, I'll answer. I am more than willing to follow up, send us an email, email me as well, and clinical questions. I can make sure to do my best to help.
Okay. Well, I'm going to go ahead and pause it right here. I'll leave this up for 30 seconds or so and let folks get that CE information. And there's a code up on the screen. You can just email that to me. And thank you, everyone, for coming today. We hope that you join us next month. And again, check us out on Facebook, or you can email me to get put on our monthly newsletter to receive these types of notifications and training announcements. So thank you, everybody.
Oh, and just before you go, just one last thing. I saw a question about using these measures for kids with developmental disabilities. I think the main part would be, as long as they're sort of their general developmental age, not chronological age, is within the age range for the measures, I think they would be appropriate. But just know that sort of more about following up about those questions and what it means. So I think it would be appropriate as long as sort of developmentally or language-wise they're within that age range, not necessarily chronological. So hopefully that helps. It was a pleasure talking to you, and please, if you want to follow up, please send emails to either Chad or I, and we'll go from there.
All right, thanks everyone.